Hi, I'm George Martin, practicing dermatologist here on Maui, and I am speaking at Rheumatology Winter Clinical Symposia 2018. One of my topics was new molecular therapies in metastatic melanoma. Prior to 2011, patients with stage 4 melanoma had basically a clinical trial as their only hope. If you're fortunate enough to have an isolated metastasis, maybe your cure rate was 20%, but the median survival in metastatic disease prior to 2011 was 6 months. Very sad situation. So we've now have the advent of two important categories of melanoma therapies. What I discussed was the immune checkpoint modulators, both the CTLA-4 blockers and the PD-1 blockers, both which demonstrate remarkable efficacy as far as halting disease progression and improving overall survival. Ipilimumab, which is an anti-CTLA-4 antibody, prolongs the activated lifetime of T cells, and in the pivotal trials and long-term extension out at 10 years, ipilimumab was shown to increase overall survival to 21% lifetime survival. And if you were alive at 3 years on ipilimumab, the chances were you're pretty much a cure. So that's very exciting news. We also see the use of ipilimumab in stage 3 disease, which is nodal metastasis. And we show an overall survival benefit of about 28% in nodal disease. However, it should be cautioned that there were some deaths in the study due to the adverse effects, which are immune related. And they are usually colitis, and that's a big thing to watch for when you have patients on ipilimumab. Flip side of the coin, we have two PD-1 blockers, and PD-1 blockers affect the T cell's ability to kill tumor cells. Once a T cell arrives at a tumor cell, we understand that there's an immune evasion that involves the PD-1 and PD-1 ligand. When we effectively block the PD-1 surface protein, it allows the T cell to kill the tumor cell. The PD-1 blockers are safer and appear to be more effective and are used in combination with the CTLA-4 antibody. However, one must be cautious about the immune-related adverse events, most of which are severe colitis, and that's the big one to watch for. On the rheumatology slide, there's some arthralgias and such, but really not much on the rheumatoid arthritis activation. The flip side of the coin is if you have a patient with RA who has metastatic disease, particularly metastatic melanoma, and you decide that that patient is going to need an immune checkpoint modulator, we recommend taking them off TNFs, going to DMARDs, but expect that about 3/4 of these patients will develop an immune-related adverse event. Usually those can be controlled with systemic steroids, and about 15% of patients you can use another immunosuppressive to get them through a reactive phase. But as it turns out, the more adverse events you have when you're on these drugs, the more likely you are to survive. And the use of corticosteroids does not appear to impact overall survival. So that's it from Rheumatology Winter Clinical Symposia 2018. George Martin signing off.